Dr. Matthew Matazar from New Brunswick, New Jersey, in the United States of America. And he will present abstract S101. And this research focuses on the combination of drugs, polatuzumab, vedotin, rituximab, gemcitabine, and oxaliplatin, for treating the type of lymphoma that has come back and is resistant to treatment, so the refractory or relapsing lymphoma. The study aimed to find out how effective this combination is in helping patients with this condition.
Thank you. And thanks for the opportunity to speak with you this morning. My name is Dr. Matt Matazar. I'm the Chief of Blood Disorders at the Rutgers Cancer Institute, and on behalf of my colleagues, pleased to share the results of our trial entitled Polatuzumab vedotin, rituximab, gemcitabine, and oxaliplatin, or POLA-R-GEMOX, or POLARGO, for relapsed or refractory large cell lymphoma. Disclaimer here, followed my personal disclosures. Polatuzumab vedotin is an antibody-drug conjugate targeting CD79B, which is ubiquitously expressed on the surface of malignant B cells. This drug delivers a payload called MMAE, which induces cytotoxicity via microtubule disruption. It's been previously evaluated and approved in combination treatments in the management of diffuse large B-cell lymphoma, both in the relapsed or refractory setting combined with bendamustine and rituximab, as well as in the first-line context combined with the R-CHP platform, a trial known as POLARIX. Here we present the results from a randomized phase 3 trial comparing R-GEMOX with or without polatuzumab in the treatment of patients with relapsed or refractory large cell lymphoma who were otherwise deemed transplant ineligible. Shown here is the trial schema of the POLARGO trial. This is a phase 3 randomized trial. After completing a safety run-in, patients with relapsed or refractory large cell lymphoma, either de novo or transformed indolent disease, having received one or more prior lines of therapy and deemed transplant ineligible, were randomized to either receive standard of care R-GEMOX or R-GEMOX plus polatuzumab. The primary endpoint was overall survival with key secondary endpoints, including PFS, complete response, and overall response rates. Shown here are the overall survival primary endpoint results, and you see here that we did indeed lead to a statistically and clinically meaningful survival benefit with the POLARGO regimen compared to standard of care R-GEMOX, with a stratified hazard ratio of 0.6, resulting in a 40% overall reduction in the risk of death with the use of polatuzumab plus R-GEMOX compared to R-GEMOX alone. Median overall survival was improved from 12.5 months to 19.5 months, and the likelihood of being alive at 2 years, the 24-month event-free rate, was 44% in the experimental arm, compared with 33% in the control arm. We improved our key secondary endpoints as well, including progression-free survival, shown on the left, here with a stratified hazard ratio of 0.37. And on the right, you see that there are improvements in overall response rate, a doubling of overall response, largely driven by a doubling in complete response from 19 to 40% with addition of polatuzumab vedotin. Summarized here are our safety results, and indeed, it is important to recognize that because there were differences in therapeutic exposure between the two arms, 7.5 cycles of median therapy with the experimental treatment, compared to only 4 cycles with standard of care, with increased exposure is likely to come increased in treatment-related adverse events, and this was seen. There was furthermore an increase in grade 5 adverse events with 11.7%, the minority of which were deemed treatment-related. The most common cause of a fatal adverse event was infection, and the most common infection leading to death was COVID-19. Please note that this trial was conducted during a period of time that was considered peak COVID. As 2 of the constituent components in the POLARGO regimen are associated with neurotoxicity, we looked carefully at neuropathy. Neuropathy was increased along with the increased exposure to therapy, but these were largely low-grade in severity, and some patients who experienced neuropathy had improvement at the time of study completion. In summary, we feel that the POLARGO data define a new and meaningful improvement in the treatment of patients with relapsed or refractory large cell lymphoma, with a 40% reduction in the risk of death compared to a standard chemotherapy program of R-GEMOX. This was achieved with an improvement of approximately 7 months in overall survival, Improvements in progression-free survival, complete response rate, and overall response rate were all consistent. We saw that the toxicity was consistent with the toxicities of the individual components. And in summary, we feel that these data really do represent a new opportunity for the treatment of patients with relapsed or refractory large cell lymphoma, both adding to our overall understanding of the rationale and role for its use in combination with chemotherapy programs, as well as giving us a new tool in the treatment of patients with relapsed or refractory large cell lymphoma. Thank you.
Please stand up because that's easier for everyone, also for people from at home. Are there any questions from the audience? Yep.
Hi, thank you. Annette Brindle from BioWorld. Thanks for taking our questions. Is there any way that you measured clinically meaningful, or how do you come to that claim?
So I would say that if you have the ability to improve the risk of death by 40%, if I were sitting at the bedside with one of my patients trying to describe these data, to tell them that in a room of 10 people like you, if we were to have used the old treatment, probably only 3 of you would have lived 2 years, but now 4 of you will live 2 years. I think that's a benefit that I can meaningfully convey to a patient and that a patient would meaningfully accept.
Any other questions from the audience? Then I have a question to you. It is very impressive results compared to the control arm that you use. But I know in other countries, other schemes are used. So how does it compare, for instance, to DAP chemotherapy or other chemotherapies that are used also in other parts of the world? Have you any idea?
It's an excellent question. So in the treatment of relapsed or refractory large cell lymphoma in transplant-ineligible patients, there are definitely varied approaches globally to the management of such patients. I would say that right now, chemoimmunotherapy remains a global standard, but not the global standard. R-GemOx is a commonly used regimen here in Europe as well as worldwide, but there are other treatments available, particularly with the advent of CAR T-cell therapy and bispecific antibody therapy. We've seen the therapeutic armamentarium expand in the management of such patients. Nonetheless, there are patients who neither have access to nor can safely receive CAR or bispecifics, and the ability to use an antibody-drug conjugate in the treatment of such patients, either in lieu of or as part of a stepwise therapeutic strategy, could add meaningful benefits.
And could it be used as a bridging therapy? Because if you have a 40% complete remission rate, that might be an option, I think, for many patients.
The question of bridging is a very important and timely one. We obviously did not study this as a bridging strategy, and questions will remain regarding the appropriateness of its use as bridging. But I will say that yes, particularly for patients who were not previously exposed to polatuzumab, who require a bridging or debulking treatment in order to facilitate delivery of CAR T-cell therapy, clearly it was not the subject of this investigation, but it would be reasonable for clinicians to see these data and consider using the POLARGA regimen in such a context.
Because for clarity, it does not deplete your T-cell repertoire with this type of regimen.
Indeed. So the history of the development of polatuzumab for relapsed or refractory disease was in combination with bendamustine and rituximab. Mm-hmm. At the time, that was felt most appropriate because of concerns regarding overlapping toxicities between polatuzumab and oxaliplatin or other platinum moieties. But we know now what we did not know then, which is that bendamustine prior to apheresis for CAR T-cell therapy can deleteriously affect outcomes with the subsequent CAR, which itself holds curative potential. So the ability to leverage polatuzumab in combination with a cytotoxic program that would not be expected to have deleterious effects upon subsequent CAR could make this an attractive strategy.
And regarding the side effects, you already mentioned something about the polyneuropathy, which is a common side effect of platinum-based regimens. Did you see any can you give more detail about the severity of the polyneuropathy, and do patients have long-term effects of this regimen?
It's an important question. We did see a higher rate of neurotoxicity, polyneuropathy, with the Pelargo regimen compared to R-GemOx. Remember, however, that because R-GemOx was less efficacious, fewer patients received multiple cycles of this treatment with a median of only 4 treatments. Neuropathy tends to be cumulative, and we did see cumulative occurrence as treatment exposure increased in the study. There was some persistence of neuropathy, so even after completion of treatment and even after study closure, some patients did have ongoing neuropathy, but about half of patients had improvement in their neuropathy from its peak severity, and approximately a third of patients would see resolution of their neuropathy.
Do you have a question still? No. Okay. Thank you, Matthew. And